All right. So welcome everyone to our weekly UCSF Orthopedic Surgery Grand Rounds. So it is our honor today to have Dr. Carolyn Hettrich as our visiting professor. So Dr. Hettrich is originally from Oregon and then went to Pomona for undergrad. And then she did her residency training at HSS. And then did a sports medicine shoulder fellowship at Vanderbilt after finishing. And then she's a real leader in the field of sports medicine, shoulder surgery. She's very active through the Academy, AOSSM, AOA, a number of organizations. And then she also has led and helped really push and develop the Moon Shoulder Instability Group, which she'll be talking about today. We have been a participating site, and so we've gotten to work closely with Dr. Hettrich through that. She's a just fantastic collaborator, real thoughtful in her approach with this, and such a huge undertaking that I think really serves as a model for what can be done on a multi-center level. And it's just really impressive to see what's been done, and then I think what's been done is only a small fraction of what will be done in the future with the cohort that she's really tirelessly put together. So Dr. Hettrich, thank you again so much for joining us. I think CASE conference was great, and then really look forward to your talk. And thanks again for being here.
No, thank you guys for having me. I think this is great. Those were fantastic cases. So I'm going to talk today about Moon shoulder instability, and it's more than 10 years of collaboration in the making. So I think you guys probably most know, but what is Moon? And so Moon stands for Multi-Center Orthopedic Outcomes Network. It was started in 2001, initially by Kurt Spindler in the knee to look at ACL reconstructions, but in 2004 was the first Moon shoulder meeting, kind of started by Jed Kuhn. Moon ACL, as you guys all know, it's a multi-center prospective cohort study. They have now over 70 publications, 4 NIH grants, and have won the Kappa Delta Award. And they've really, I think, produced some data which has changed the treatment of ACL reconstruction. Again, Moon shoulder, this was 2004, although this picture was in 2008. And I think you guys will can all recognize these two people here as being some of the initial members of Moon, and really being instrumental in getting the group started. They first started with a rotator cuff study run out of Vanderbilt, where they had 433 patients, and they looked at predictors of failure for non-op treatment of these rotator cuff tears. It was great. They put patients into a physical therapy program for 8 weeks, and that data, again, has really changed treatment and won a couple of NEAR awards. And this is kind of the big graph that I take away from what they've done, where you can see that after this physical therapy protocol, 20% opted for surgery. They did it at about 4 months, by 4 months post-op. The interesting thing that really I think that they found was structural factors and things that we want to see, the objective findings that we look at on MRIs, and in terms of weakness, tear size, atrophy, those were not predictive of kind of moving to surgery. It was patient expectations of treatment. Again, I think this data really changed how I think about treating rotator cuffs disease. And so coming out of fellowship, I was interested in starting some research, and I really wanted to do high quality research and produce the best data. And so, trying to think of what study design. So why a cohort study? And as everybody here knows, there's this hierarchy of evidence, and looking at it with rotator cuff tears, cohort studies, then going down to kind of expert opinion. And again, randomized control trials are felt to be the gold standard because they deliver the highest level of evidence, and that's kind of the best thing is said to be, and some of the biases towards that for doing studies. But again, are rotator cuff or randomized control trials the best for all research questions? And that is definitely not the case. And so if you look at a lot of behavioral or qualitative research, there's just some things that you obviously can't do a randomized control trial for. And, and especially kind of the psych topics. And again, in surgery, it's hard to often do a randomized control trial because there's so many things that go into it. Like you said, differences in pathological findings, surgeon skills, different choices that are made, their anesthesia that they're given, post-op care. And while there are studies done in the literature that use sham controls for surgeries, especially around the meniscus, there is one done for shoulder surgery. Most IRBs, I think you'd have a tough time getting that approved and getting patients to kind of sign up for that. So oftentimes it's just not realistic to do that. Also, it's really hard to do a randomized control trial if there's low event rates. So failure like auto versus allograft in ACLs, glenoid fractures after reverses, infection, you would need thousands of patients, and that's just not a practical thing. So a cohort can be better, again, looking at things with low event rates. You can adjust by age and you can apply to individual patients better than you can in a randomized control trial. If you have to do a complex treatment, like I said, in some of these behavioral or surgical, or if you lack equipoise. And, again, the cost can be less, and you can use these cohort studies to establish the premise for future trials. So with that, we decided to do moon shoulder instability, and it started in 2011. And I can't believe how long ago that is now. Looking at predictors of failure after surgery for shoulder instability and predictors of outcome. And for the purpose of our group, failure of surgery is defined as revision surgery, repeat dislocation, or subluxation. We modeled it a lot after the moon ACL, and this was done by myself and Brian Wolf out of Iowa. But it does take a huge team and a lot of collaboration to do this. And so you can see we have many sites and a lot of great surgeons that work with us and have done a fantastic job. And you can see up here on the top that UCSF has always been kind of heavily involved in this and done a great job working with the Moon group. It takes a village, and the research staff is also instrumental in terms of getting these projects done and kind of doing a lot of the heavy lifting of them. So we had to do a lot of background work with these studies. And so a lot of people will be like, oh, you've been collecting data for 10 years. Do you have 10-year data? Well, absolutely not. We're still finishing collecting our 2-year data. And so it just takes a long time to get a lot of these things up and going. So we did some agreement studies to start, literature reviews, had to decide what patient-reported outcomes we were using, and then do a lot of instrument design. So one of the first things we looked at was this inter-observer agreement and looking at labral tears. And we did this looking at kind of surgical videos. And we saw that we were pretty good in terms of inter-rater agreement at looking at the anterior labrum and Hill-Sachs. We weren't very good at looking at the inferior labrum and meniscoid superior labrum. This is looking at anterior instability imaging. And so we only had fair to moderate agreement when looking at imaging studies without clinical data. And, this was a little concerning, but I do think when you have clinical data, arthroscopic data, some of these things get better, but we only had fair to moderate agreement. We had to decide on physical therapy. So we did an extensive literature review trying to find what the best physical therapy protocol was. And it ended up that wasn't clear based on the literature. So we did consensus-based PT protocols, kind of combining the whole group's PT protocols and then just coming to agreement. We decided on inclusion and exclusion criteria. Our inclusion is very wide. Anyone over the age of 12 needing surgery on their labrum or capsule, and excluding people that have significant rotator cuff tears, fractures outside of Hill-Sachs, arthritis, work comp, prisoners unable to consent or follow up. We have an extensive amount of patient-reported outcomes that we were collecting, including everything on this list, where it's a lot of the standard kind of shoulder questionnaires, and also looking at patient expectations and some kind of psychiatric questionnaires as well. You have to standardize some aspects of your treatment, and we standardized post-op care, PT, what radiographs we were collecting, and what slings we were using. And again, collected at time zero additional demographics, physical exam, imaging findings, an exam under anesthesia. We've got to collect a lot of surgical data. And so the surgical data on the pathology that's within the joint, as well as the treatment. And this is kind of the picture that we use here on the bottom right. If you just do a labral repair versus like a 5 millimeter or a medium amount of capsular tightening versus a larger amount of capsular tightening. At 6 months, we do a physical exam in which you look at range of motion, strength, and apprehension. and also collect any failures at the 6-month time point. And then the plan now is for data collection at 2, 6, and 10 years. And again, looking at PROs, failure, and return to sport. So as of right now, we're the largest prospective cohort of shoulder patients in the world. We have 1,646 patients actively enrolled, in which about 1,250 are anterior and almost 400 are posterior. And we do include both primaries and revisions. Looking at the numbers for primaries and revisions, we have about 249 revision cases and almost 1,400 primary cases. Looking at how these are split between beach chair and lateral, this again kind of reflects the composition of the group, and a lot of people were trained it kind of out of HSS, and so that we have a kind of preponderance of patients, about 65% in the beach chair position. Most of our patients are males, only about 20% are females. We have 208 Latarjets, 86 remplissages. Looking at kind of baseline demographics of the group, average age is 25. Again, BMI is 25, about 5% are smokers. If you look at the number of dislocations, 23% for anterior have had 1 dislocation, and about 25% have had more than 5. So pretty good spread with numbers there. Looking intraoperatively, the big thing is you'll see about 31% of patients have a significant Hill-Sachs, and about 55%, again, that's greater than 10% of a significant bony Bankart lesion. And so that helps with looking at some of the bone loss studies. Again, the posterior characteristics, patients are a little bit younger at 24, a little bit bigger with a BMI of almost 27, same smoking. Again, they've only about 12% with solitary posterior dislocations, same thing, about 21.5% with greater than 5. Looking at the data, at more than 10% bone loss, these are significantly smaller, as you would expect, 21% of patients with the reverse Hill-Sachs, and as well as with glenoid bone loss. So the big thing that we started out doing is looking at our time zero studies. So what have we learned about patients at the time of surgery? So the first thing we did is kind of take a look at what makes up this group, what makes up the Moon shoulder group. So we looked primarily at ages, and here's kind of a graph looking at the distribution of age and gender within the study. So most of our patients are quite young. Again, the average age falls to be around 25, and looking at the direction of instability in who we've enrolled. Most of our patients are white at 87%. Here is the breakdown in terms of number of dislocations. So 0 is about 25%, and those would primarily be subluxators or subluxations. 1 single solitary dislocations is 18%, 2 to 5 is 32%, and greater than 5 is 24%. These are the sports that were primarily where the injury occurred. You can see it's football, basketball, and wrestling. And again, that reflects kind of where our sites are. So, when you have some of the Midwest sites have a lot of wrestling. This is looking at the radiographic findings of the cohort, and you can see the amount of kind of bony deficiencies. Again, when you look at the CT scan, 98% of a bony deficiency, but that's a product of that's who you order those on. And looking at MRI findings, the most common findings are an anterior labral tear. So what's the differences between males and females, looking at that, and that's important to kind of understand. So this, we used 1,010 patients, and you can see that the patient-reported outcome scores were consistently lower in females. Females had more reports of back pain, more depression. Males were more likely to have a traumatic injury or injury that occurred during sport, had higher pre-op activity levels. But the interesting thing is they were not likely to have had more than 1 dislocation. Males, again, were more likely to have glenoid defects, higher rates of Hill-Sachs lesions, and increased rates and higher grades of labrum pathology, which again, you'd expect in more of those sporting and traumatic injuries. Females had higher rates of capsular laxity or tears. So is there a difference in patients with 1 dislocation versus more than 1? And this is a very hot topic now and things that we discuss in shoulder instability. So this again was an early study, and this was done again here out of UCSF, and looking at 172 patients, depending on the number of dislocations that they had 58 patients with a single dislocation. So they found that preoperative imaging revealed increased glenoid bone loss in patients with multiple dislocation events, and recurrent dislocators are more likely to have bony Bankart lesions and biceps pathology. They were also first-time dislocators were more frequently underwent arthroscopic Bankart repair versus recurrent dislocators were more likely to undergo a bony procedure such as a Latarjet in treatment for their biceps pathology. So again, the conclusion was first-time shoulder dislocators who undergo arthroscopic stabilization are more likely more likely to have an arthroscopic stabilization and less likely to have bone loss or biceps pathology. And that's significant because that's a much kind of smaller surgery. So how active are our patients compared to the general population? So 77% of patients had a higher shoulder activity level than sex and age match controls. This was higher in the younger patients. If they're 18 to 30, they had higher shoulder activity, 79% and higher shoulder activity than in controls, and males and females were the same. The older patients, the 31 to 50-year-olds, that was a little less. It was only 70% had higher activity than controls, and that was more in males than in females. So are seizure patients different? So all of us have in our instability practices these seizure patients. The interesting thing to me was there weren't as many as I thought there would be. There's only 25. This again was done primarily out of UCSF. There's 25 out of about 1,300 patients at the time. They had similar sex ratio, age, and incidence of posterior instability. And again, I would have also thought that there would have been more posterior instability, but there wasn't. It was not significant. But they did have more dislocations in the past year, increased bone loss, and more open procedures. So what is better, beach chair or lateral? And that's, again, a commonly debated topic and that happens at these meetings. And again, that's highly dependent on training, and people tend to only do one or the other. So again, there's the lateral decubitus position. This is kind of an image of this. There's some advantages of which for visualization of the inferior glenoid, there's a lower risk of cerebral hypoperfusion from anesthesia, but there is a risk of traction injury. Beach chair is kind of advocated for because it's an easier conversion to open, many feel, but it's a little bit difficult to distract the inferior glenohumeral joint. And this is kind of, again, an East Coast bias and where a lot of people trained. There was a study done on this, a meta-analysis by Rachel Frank, who's also part of our group, and she looked at recurrent instability and found that lateral decubitus had an 8.5% rate of recurrent instability. Beach chair was higher at 14.5, but they did have longer follow-up. So this is the methods of our group. Again, this picture here shows kind of what we fill out when we look at where we put our anchors and where the labral tear is. Each little circle that we have up here is about 18 degrees. And looking at this data, we kind of grouped everything into quadrants. And this is as done by Boileau, kind of an anterior, posterior, inferior, and superior quadrants. We had 614 patients. They were similar in terms of age, sex, race, and smoking. However, again, the lateral decubitus did have in that group a larger percentage of people with more than 5 dislocations, and instability had lasted for more than 1 year. There's no difference in patient-reported outcomes, but there was reported that the labrum tear length was reported to be longer in the lateral decubitus group, and there was more documentation of tear involvement in the inferior quadrant, and there was no difference anteriorly or posteriorly. So anterior posteriorly was the same, inferior was longer. There was no difference in the number of anchors placed in the anterior posterior quadrants. That was the same. But in the inferior quadrant, it was less were placed in the beach chair position. And if you look at the rates of having 2 or more anchors in the inferior quadrant, the beach chair was 22% of patients, and the lateral decubitus, it was 54% of patients. So about this longer average tear size, did they have more tearing inferiorly because the groups are slightly different? Or, can the surgeons just see better and report more of it in the lateral position? We don't know. There were more anchors inferiorly in the lateral decubitus group. Again, was it because it's easier to see or for instrumentation, or is it a difference in philosophy? And will this actually play into outcomes? So we don't know that at this point, but those were kind of the baseline data. So what predicts larger labral tears? So when you see a patient in the office, who is more likely to have a large tear? We defined a large labral tear as greater than 270 degrees. So it needs, a significantly larger procedure, more anchors, more time in the OR. So of that, in this study, there's 1,200 patients that were included. The average tear size was about 142 degrees, and 4.6% of those, or 57 patients, had these really large tears of greater than 270 degrees, and most of these were in males. So we found some interesting findings with this, and these racket sports, swimming, softball, skiing, and golf were kind of associated with these larger tears. Age, race, history of dislocation, and injury during sport were not. But the more interesting finding was, again, what you can see here on this graph. If you had a larger BMI, so BMI is down on your x-axis, and you played contact sports, you're more likely to, as your BMI increased and playing contact sports, to have a large tear, versus if you didn't play contact sports, as your BMI increased, that seemed to be protective. So that was an interesting finding. Are patients different who also have back pain? So this was mentioned in the female versus male study. But if you ask patients, do you have back pain? Patients with back pain tend to be older, more female. There's no difference in imaging or intraoperative findings. But if you had back pain, you had worse patient-reported outcomes than if you did not. They also had more frequent depression, poorer mental health status on all of the analyses that we do for kind of looking at psychiatric or mental health analyses, and worse preoperative expectations. So that's something I think that you can flag in a lot of these patients that come in with shoulder instability. If they do have back pain, I think that taking that into account when you're talking to people is going to be important. I think one of the more important or interesting studies we've done is looking at racial disparities in patients undergoing shoulder instability. As we know, there's a lot of arthroplasty studies that have shown that there is a lot of disparity, but it hasn't been studied in shoulder instability, and this is a much different population in that they're younger and have more acute events. But recurrence does result in increased articular pathology and improved results with earlier treatment. How we looked at this is we used the Distress Communities Index, which is a measure of economic distress as determined by zip code. And you can see it here on this graph. Again, if it's red, it's distressed. If it's blue, it tends to be more prosperous, kind of going from there. This analysis was with 1,010 patients, 158 which were minority patients, and the breakdown in terms of age, sex, BMI was the same statistically. Looking at patient-reported outcomes, there did not meet MCID between groups, even though there was some statistical differences. But the big things, if you look between minority and Caucasian groups, the Distress Community Index score was higher or worse for the minority groups, and there was a higher percentage of patients on Medicaid. Looking at shoulder pathology, and these were specific, these were significant. Dislocations more than 2, articular cartilage lesions, significant glenoid bone loss, Hill-Sachs lesions, and bony augmentation surgeries were much higher in the minority population. So again, they had increased number of dislocations and more severe glenohumeral pathology. And we know from previous studies, if you have increased bone loss, you'll have worse outcomes. So the big question is, why is this occurring? And is this due to access to care? And some people hypothesize that this was due to having Medicaid. But this was a very small percentage of all patients, and it was found through our analyses to not be an independent predictor. Cultural differences in surgical utilization of patient beliefs and attitudes towards healthcare, trust, and possible provider biases. So it's something that we have to be aware of in this disparity in discussions with surgery earlier with minority patients. And will be something that, again, for a research study in the future would be really interesting to kind of look at, so we had a better idea of why this was happening and the impact on outcomes. So what is the incidence of bone and cartilage lesions for revision versus primary anterior surgery? So this is, again, looking at 545 patients. Revision surgery patients were older, more frequently smokers, greater number of events. They had more likely to require reduction assistance, and they had a lower WOSI. They had a higher frequency of bone and cartilage lesions than those undergoing primary surgery. And this is kind of, what you would expect out of a revision population. What is the incidence of bone and cartilage lesions for posterior instability? Again, this was another study that was headed out of UCSF. where it looked at 271 patients with posterior instability, the glenohumeral joint being evaluated at the time of surgery. What they looked at is outer grade 3 or 4 glenoid humeral cartilage or glenoid or humeral cartilage lesions, reverse and Hill-Sachs lesion, or reverse Hill-Sachs lesions, and bony Bankart lesions or glenoid bone loss. They found bone and cartilage lesions in 54 patients, or about 20%. Glenoid cartilage injury was the most common, and increasing age and 2 to 5 reported instability events were predictive of the presence of bone cartilage lesions. And it was interesting that this greater than 5 dislocations didn't necessarily have more injury, but a lot of these are some of your atraumatic dislocators, or probably still thought of as the MDI patients of the past. And as we know, those don't tend to have, due to their capsular laxity, as many injuries. So for bone lesions alone, the instability events was the only significant independent predictor. And they concluded that bone and cartilage lesions are seen more frequently with increasing patient age and patients with 2 to 5 instability events. And so early surgical stabilization may be considered to limit the extent of intra-articular injury. So now moving to studies at 6 months post-op, and there's only really one that's been done to date here. And 6 months, again, we have physical exam findings and we find out about failure. So what predicts poor motion or strength at 6 months? And the 6-month time points is important. That's when a lot of us start to clear patients to return to play, to sport, and to get back to kind of more demanding jobs. So we're 348 patients, and we found that 74% had returned their motion to baseline. And that means they were within 20 degrees of where they had started in terms of motion. Interestingly enough, it was a higher Baton score, or more tissue laxity, and higher number of dislocations, which were associated with a failure to regain baseline strength and motion. And no surgical variables were found to influence this, including primary versus revision surgery, open versus arthroscopic, number of suture anchors, some things that I would have thought would have influenced this, but did not. So looking at 2-year data and outcomes, and again, this is much smaller. We still, at this point in time, we have about 930 patients that have reached their 2-year point. We still have of our primary cohort of anterior primary instability cases, about 70 more to collect. We do have a couple small studies looking at 2-year data. So this is looking at our stats at this point from what we've collected. So of our anterior, this is all anteriors, revisions and primaries, 4% have had repeat surgery. Of those, 3.3% were from redislocation. So about 4.3% of patients have a repeat dislocation, and 19.2% of patients have had a repeat subluxation. So looking at primary anterior, so anterior, but just the primary cases, excluding revisions, again, about 4% have had repeat surgery. All these but one have been for redislocations. 4.5% of patients have had a repeat dislocation, and 18.2% have had a repeat subluxation. Looking at the same statistics for posteriorly, repeat surgery is much less at 2.7%, dislocation at 5.9%, and repeat subluxation at 17.1%. So our Michigan colleagues pulled together and looked at some of the outcomes in overhead athletes. They were found 49 overhead athletes with primary arthroscopic surgery on their dominant arm. And they found that 63% of these athletes had returned to sport, 58% at the previous level of competition, and they had significant improvements in their Kerlan-Jobe scores. And they had recurrent instability was in two of these patients, 4.1%, who both were revised. So they found that age, gender, and baseline level of competition were not predictive of return to sport. There was no difference in range of motion in all planes between the returning sport and those that did not. So it wasn't due to stiffness. And they found that primary arthroscopic anterior shoulder stabilization overhead athletes was associated with a low recurrent rate of instability, but their return to sport at short-term follow-up was lower than previously reported for the general athletic population. And it'll be interesting to see if this follows through when we get more patients to look at. And the last study we have that kind of published at 2 years was looking at the results for the FEDS classification. And FEDS is how I classify shoulder instability. And again, it looks at frequency, etiology, direction, and severity. Frequency is solitary, occasional, or frequent dislocations. Etiology, if it's traumatic or atraumatic, which direction it occurs in, and that's based from both history, physical exam, and exam under anesthesia, and then severity, if there's a subluxation or dislocation. So 1,200 patients were assigned to the FEDS category. The most common categories were further analyzed, but for patient-reported outcomes and modes of failure. So the FEDS classification can be a little intimidating because it does give you 36 potential kind of categories that patients can fall into, which is a lot. But only 16 of those 36 had more than 1% of patients in them. So you would kind of ignore the other ones. Occasional traumatic anterior dislocation, occasional is 2 to 5 dislocations, was the most common category with 16.4% of patients. And 5 other categories of anterior categories and 1 posterior category represented at least 5% of the patients. So looking at this chart, if they're blue, they have more than 5% of the patients. Those are kind of the predominant classification that occur. Gray is ones that really didn't have anyone in them, and the white boxes have more than 1%. PROs improved significantly for each category, but there was a downward trend in patient-reported outcomes and higher failure rates if you had increased number of dislocations. So this is looking at your patient-reported outcomes. They did worse, and you had more failure again as you'd had more dislocations for the most part. So lastly, what I want to do is just quickly go over some unpublished data. Again, this is not peer-reviewed and not published yet. But it's some of the kind of more fun things we have coming out. Again, we're slowly reaching 2-year maturity. It's been going for over 10 years. We've been working on this, but it takes a while to recruit these patients. And so we're just kind of coming up on that and getting to the point where a lot of our 2-year outcomes are going to come out. Looking at maladaptive psychological traits and voluntary dislocators, who should we be operating on? And the reason this is there was this Carter Rowe patient in 1973 looking at voluntary dislocators, and they said that patients with significant psychiatric problems did poorly after all types of surgical and non-operative treatment unless the psychiatric problem had been resolved. And so the big thing that I was taught in my training, and kind of the mantra with a lot of instability surgeries, was if the patients have psych issues, to not treat them, and because they're just not going to do well. And so we wanted to look at that. So we at the time took 630 patients that had 2-year follow-up. We had follow-up on 92.7% of those. We looked at, again, their DROs, whether or PROs, whether they're a voluntary dislocator, intraoperative data. And one of the things that we collected was this personality assessment screener, which I know a lot in orthopedics aren't necessarily as familiar with. It's a 22-item short form screening tool. And if you have a score over 19, there's a good chance that you have clinically significant maladaptive behavior in at least one domain. And this is what it is. And these are kind of these maladaptive things and these domains. So this doesn't tell you a specific diagnosis, but it is good at kind of screening for some of these things. 584 patients were available. So about 20% had this screening score of greater than 19. So might have these maladaptive traits. This is the distribution of PAS scores, again, 20%. And if you look kind of at how those are cut off, looking at maladaptive, looking at dichotomous scoring, PAS score of greater than 19 was associated with smokers, black race, depression, needing an aid for reduction, symptoms greater than 6 months, and bone cartilage lesions. Looking at PROs, again, they had inferior VR36 mental component scores, ASES and WOCI's pre-op, and some of the same ones, again, post-op. The posterior dislocation rate in these patients was 8.4%, 29.7% reported subjective instability, and subsequent surgery was in 4.8%. There's no difference in the post-operative instability rates for patients with or without these disorders. Some of the interesting data really comes out of this looking at volitional instability, and this is going to be presented on at the Academy. So But really, when you start to look at these PAS scores, and the PAS score is on the x-axis, when you start to get around 20, what you'll see is the probability of failure if you're a voluntary dislocator, which is the kind of the yellowish goldish line here, starts to go up significantly. So there's really no difference in the lower PAS scores, but as soon as you get to a higher PAS score, there is definitely a difference in terms of failure. This is looking at the same thing by gender. And so males and females, voluntary dislocator, if it's yes, it's in gold. So again, when you start to get around that 20 range, you're going to have a much worse mental component score if you're a voluntary dislocator. This is, again, looking at the same thing, your PAS score, again, in the lower 20 range. When you're a voluntary dislocator, your score is much worse. Post-op, either both for primaries as well as revision surgery. So it held up for both. So again, concluded from this study is nearly 20% of patients undergoing shoulder stabilization surgery have these maladaptive kind of conditions. Is this a cause or the effect? Is this the chicken or the egg? We don't know if the shoulder instability makes people have these or if they had them beforehand. We know that patients with these conditions have inferior PROs at baseline and a 2-year follow-up. They change the same amount, so they have the same incremental increase, but since they started lower, they end lower. Volitional instability dislocators have worse outcomes if they have a PAS score above 20 to 22, and future studies should examine the role of intervention. Like, are there modules and online modules that you can do to maybe help with some of these? And lastly, one of the that we've submitted for submitting for publication is looking at predictors of bone loss in patients of anterior shoulder instability. And so this is a big question we have, because we know that bone loss is critical in predicting the success of a lot of these procedures, and as little as 13.5% can mean significantly higher failure rates with arthroscopic Bankart repairs. And bony procedures are needed above a certain threshold. What we did in this study is we set up these proportional odds models where we looked at for anterior and posterior glenoid bone loss, as well as anterior and glenoid bone loss over anterior and posterior over 10%, and then combined lesions. We chose the variables for our models. And so in our models, it included age, sex, and race, BMI, contact sports, laxity, activity level, traumatic, yes or no, the number of dislocations, pre-op PROs, your personality assessment, screener scores, your mental component scores, and your apprehension on pre-op physical examination. So we use the perfect circle method for bone loss determination, and then also looked at this intraoperatively, and were classified 0 to 10%, 11 to 20%, 21 to 30%, and greater than 30%. Looking at anterior bone loss, and so what was predictive here is if you looked for age, sex, and race, you were twice as likely to have anterior bone loss with repeat dislocation, white versus non-white, contact athlete, and number of shoulder dislocations. Again, if you had a repeat shoulder dislocation, you're 81% percent more likely to have have bone loss. What we're able to produce for these is these nomograms. And so how these nomograms quickly work is there's a points up here on this axis. And so if you're, let's say 16 years old, you would get 10 points. If you were male, you would get 30 points. And for each of these things, you kind of add up points. If you're a contact athlete, that gives you around 30 points. And you start for all of these factors kind of adding up your score. Depending on what your total points is, it would kind of predict your probability of glenoid bone loss if you had a subsequent dislocation. We did the same thing again for anterior bone loss of greater than 10%. Again, this nears that threshold. We have to start thinking about bony augmentation. A lower activity was somewhat protective. If you have had a second dislocation, again, your odds ratio is 2.57 in terms of having bone loss with your next dislocation. Looking at posterior bone loss, or usually or Hill-Sachs lesions, again, males were much more likely if you're non-white, and if you had anterior apprehension for posterior bone loss. Same thing with number of shoulder dislocations. If you had another dislocation, you're 35% more likely to have that happen. Looking at greater than 10%, so larger lesions, again, it was age and the number of shoulder dislocations. Combined bone loss, again, age, which was slight, non-white race, as well as number of shoulder dislocations. Again, if you had a subsequent dislocation, you were much more likely to have bone loss. So the increasing number of preoperative dislocations was a significant predictor of bone loss in every model. It was the most important modifiable risk factor. Contact sports and activity level were modifiable predictors for anterior glenoid bone loss only. Since this can result in needing a bony procedure and increased failure rate, and likely leads to increased post-traumatic OA. So the big question is should we be recommending surgery earlier to patients? And, I like to think of AC, this is kind of ACLs, where if you have contact sports and if you have patients that are young and male, that you really should be thinking about having surgery after your first dislocation. We do need larger prospective studies, as well as probably randomized control trials to look at this. This is just a list of the published manuscripts from our group. In the future, again, we're hoping to work with you guys and looking at analysis of our time zero imaging, because we have MRIs on the majority of, or CT scans on the majority of patients. We've stopped enrolling for primary anterior, but we still are enrolling for revisions, lateral J's, and posteriors. We're collecting follow-up data. That's kind of the main thing that we do at this point in time, and starting to get ready to produce our 2-year results. So our funding for this has been internally out of University of Iowa and ORAF. And we do have social media. It's not super active, but you can look at results on Facebook, Twitter, as well as on the website. And the website has all the physical therapy protocols, who's involved and whatnot. And I'd like to thank you guys for listening.
Great. Thank you so much. It really is so impressive, and like everything that you presented, I think it's really impacting how we manage instability patients, but then it's also like so exciting to think about everything that will be done with like the huge cohort that's been assembled. And so congratulations on everything with that. And I think with that, we can open for questions, comments, discussion. Feel free to raise your hand, unmute yourself. See, Dr. Ma.
Dr. Hettrich, thank you over there. I think that, for the audience, I think that I get to work with her for the past 10, 12 years. It's kind of very impressive what she's done over, a short period of time. I think that, it's kind of evident from some of the data she's shown, here. And I will probably, say something maybe different. Dr. Hettrich, if you don't mind sharing with us, we have a lot of residents and learners on the call. What prompted your idea to do this? I think that just to put things in context, Wound Shoulder was started when I was a really young pup. I think it was my first year in practice, in Washington, D.C., where I kind of came with an idea. Yeah. And Carolyn finished fellowship, she kind of joined the group in Iowa and kind of have this idea with wound instability. What prompted you to have that idea, and how do you get things started? I think that would be more inspiring for the group to hear about, because these guys will be finished pretty soon. What drives you, to do this, and what are the things that you now that you would advise people, when they kind of think about doing these large database studies? Yeah,
I think in terms of my background, I have an MPH, and so I've always felt the drive to produce things that were higher level of evidence and kind of high quality studies, and that led me to fellowship with Kurt Spindler and Jed Kuhn. That was kind of one of the major factors things that was really attractive to me about working with those guys, and was definitely impressed by, when I was in, again, fellowship, which is 2010, by the things that were coming out of Moon ACL, and they were starting to have some pretty significant findings, and I could see that was changing care. And at that time, it was especially the differences in using allograft in young patients, where they had some very clear data that if you used allograft in young patients, you had significantly increased failure. And I could see where that was could potentially help a lot of people. And so was interested in that. And over my time of talking with, Jed Kuhn, who I was there for fellowship, wanted to do something where I could be involved with producing significant data that could affect patient care. Was looking at the different, kind of diagnoses and things that interested me the most. And instability was one that I felt had a lot of unanswered questions, and kind of started to then talk to him and talk to the group and, see what the interest was in there. I will say that if you look at the things that I've done in my career, it was probably hands down the best thing that I've done. And it's a lot of work, but it's been starting to really pay off in terms of, what it's producing, and not just in terms of articles, which you need for academic promotion, but just in terms of starting to produce some really interesting and thought-provoking information. And so what I would encourage trainees is when you first start out in practice, you're not as busy, and so that's your time that you can really, if it's not set up for you already, start to think about setting up your outcome systems and what you're going to do, and starting collaborations. And there's a lot of things that you can do. And I know, at least in AOSSM, they're trying to kind of help get some of these emerging leaders together so that they can form some of these groups. But it really gives you a data set and a population to really work with. And so I do think that while it's challenging to do this when you're younger, because you haven't earned necessarily the respect of your colleagues. And so when you have to call and harass people to make patient calls and things like that, it might not be as easy. But I do think that is the optimum time to kind of start doing something like this. So as a trainee, I would start to think about if you'd want to start something like this early, if you can.
Great. I see a hand up from Dr. Zhang.
Yeah. Hey, thanks, Carolyn, for that excellent talk. I think that was really, really great. And I think the main story is that we're just kind of getting started with this, and we haven't even started reporting the majority of the results. So there's going to be much, much more to follow. And I just had a question. I've been meaning to ask you this at the meetings, but I keep forgetting. But one of the surveys, the operative form questions is about implants that we use for our instabilities, like peak anchors, bioabsorbable, all suture. Have you started to look at that a little bit yet in terms of any differences in failure rates based on implants or suture type or anything like that?
So we did look at that. I actually hid the slides on it. We did look at that kind of with about half of the cohort. The really interesting thing was found that if you looked at knotless versus tying knots, for example, when we first did kind of just the univariate analysis, the failure rate was twice as high for knotless anchors. And this really kind of shows you. But then when we did a multivariate analysis and then took into account, especially patient age, that lost significance, but it's close. So the P was 0.056, I believe. So greater than 0.05. So it went, now that we have larger patient numbers, it'll be interesting to see if that does reach significance, because it wasn't quite there. But there didn't seem to be a difference in knotless versus, or excuse me, in all suture versus using standard anchors. But there was moving towards significance in knotless versus tying an actual knot. And again, it was pretty striking at first, but the multivariate, it happened to be that a couple of the surgeons who were using a lot of the knotless anchors had a much younger population. And as we know, age plays pretty significantly into recurrence. And so that is going to be one of the primary things primary variables in our multivariate model that we use looking at failure going forward.
Great.
That'll be really helpful information, Carolyn, about the knotted versus knotless anchors. It will be very applicable in our practice at San Francisco also. So yeah, thank you. Yeah.
So Dr. Hettrich, maybe one question. What's been the biggest challenge in setting up and coordinating such a huge undertaking?
At first, the amount of work is a little bit intimidating, I would say, because you have to figure out, what outcomes you're going to use. So what are the best outcomes? And you live with your decisions. And so, and when you're setting up your forms, and we made some errors, in terms of, we didn't have quite ask some questions. For example, we did the Feds classification, which looks at dislocations in the last year, but for our first 150 patients, we didn't get their total dislocations, and so that seems like a pretty obvious oversight. But when you're developing these huge questionnaires, oversights, hindsight's, 2020. And so, you will have some of these things, and, kind of figuring out, like you said, some of these agreement studies and getting going. But once you kind of overtake or get past that, I would say the hardest thing is study's been going on for 10 years. And so it's maintaining motivation within the group to keep enrolling, because, it's been going on for a long time. And I think that, it's not as exciting for people necessarily at all points in time. And, surgeons are an independent, kind of group. And so sometimes it's trying to get, that people to make calls and do the things that we need to get the higher levels of follow-up. And getting that higher level of follow-up is really important to maintain a higher level of evidence. You should have 80% follow-up, and that threshold's actually quite tough. And so, we're about to, after the academy, start, another push to get follow-up and to close out some of our follow-up periods. And it involves sending a lot of emails and a lot of text messages and harassing people. And so, that part can be difficult as well. Get ready, my UCSF colleagues.
Any other thoughts or questions from our audience? Maybe one more. So with everything you've seen, has your approach to like the first time dislocator changed? And what's your current, like for a, adolescent or, younger person, first time dislocator, what are you counseling at this point?
So when I trained, you were very much taught, if you had someone dislocated in sport, you would, make sure they had full range of motion, strength, get them back to return to play, finish their season. And, a lot of the timing of reconstruction was based, or a lot of the reconstruction was a lot based on, timing of their athletic season. And you'd most often would give them kind of a chance at this conservative management. And there didn't seem to be a lot of emphasis on fixing the first time dislocator. I think that as this data and other data from other groups has come out that really show that with subsequent dislocations, you have significantly more, bone loss, cartilage lesions, that I've moved a lot more towards fixing that primary dislocator. And while we don't know definitively, and we're working on kind of showing with some of this imaging data and long-term follow-up that having those lesions does affect like things like post-traumatic OA and outcome afterwards. Now, if I have a young patient, especially who's a male who does contact sports, I really push much harder to fix them early, to fix them much earlier than I used to before. And I show them that data, and we're working on getting those nomograms online, so you can kind of predict with a subsequent dislocation their risk of having more bone loss. And so I'd say I'm much more aggressive now with the first time dislocator. And I really do think that over time, this will evolve to thinking about this like we do an ACL. We wouldn't take, or most people wouldn't take an ACL in a young contact athlete and put them right back into sport.
Great. Anything else that from our audience today?
Yeah, I think the first time dislocators are always controversial. I mean, I think, Well, if there's any way we could kind of answer that, I think it's great. But I think it's always challenging. You know, I think we know who the high risk groups are, and I think that surgery also is not 100% successful. Obviously, in this group, right? Young active people, contact sports, the failure rate could be as high as almost 25% on these young patients over there. So that's why I tell them to is even when you fix them, it's not foolproof over there, but if you don't fix them, there's also issues. So I think it's still a dilemma we have, and also a conversation we have to have with the young athlete and also the family also.
Exactly.
Great. Well, we're just about at time, so I think we'll wrap up there. But Dr. Hettrich, thanks so much for joining this morning, and then also for leading this large cohort, and then having us as a participating site. It's always great to work with you. Great to see you today, and thank you all for joining today.
Yeah, thank you for having me.
Thanks.
Thank you. Yeah.